Yes, I do have it. So we need to see. I'm waiting for Dr. Sharma.
The ma'am has joined just now.
Ma'am has joined? Okay, very
Yes,
good.
sir.
Hello,
Hello, ma'am.
everyone.
Hello,
Hi. Hi, Dr. Kripa.
Hello, Dr. Sharma.
Hi, ma'am.
Hello.
I'm Dr. Ravi Nair. I have the honor of being the person who conducts this meeting. And I'm sure that we are going to open out a lot of information for everybody. Can you hear me?
Yeah, I can hear you.
Yes, can you hear you, sir?
Yeah. Okay, fair enough. So, can I commence the meeting? Do we have enough quorum?
So 30 members roughly are on board. So I think we can start off, sir. Yes, other members will be joining shortly.
I think we can start. No, 30 members is a good number.
Yes.
So let me start here by first and foremost asking our presenter to say a few words about himself. Dr. Abik, where do you practice? Tell us something about yourself. If you could be brief, I would then... Go ahead.
Yeah, sir. Sir, I am in Indore, Madhya Pradesh, the cleanest city of India for 6 times in a row. I am a DNB PG teacher in Choitram Hospital in Indore, and we are running DNB in since the last 5 years. We are the only institution in Madhya Pradesh which is running the same. I have done my MS from UT Medical College in 2005, and I have done my DNB in the same year. I'm also a member of National Board of Medical Sciences.
Okay.
I basically belong to West Calcutta. My MBS is from Calcutta National Medical College.
Okay, but you prefer to settle in central India.
Yeah.
That's very good. Dr. Sharma, could you tell us something about yourself, because you are technically an honored guest as a neurologist. The one subject we all enjoyed in undergraduation, but thereafter ran far away because it was generally assumed that only the brainy people take neurology. So, Dr. Sharma, tell us something about yourself.
Thank you so much, first of all, sir, for the invitation. And this just reminds me, before I tell anything about myself, I'll just tell you a joke regarding what you just said, that brainy people take neurology. You know, what happens is that sometimes one of the patients was told by my colleague, not ENT colleague, but medicine colleague, that your problem is something else. तो ये आपको basically दिमाग वाले डॉक्टर को दिखाना है, तो आप जाके दिमाग वाले डॉक्टर को ये डॉक्टर को दिखा लीजिए. वो बोले कि डॉक्टर साहब, हमें तो लगा कि आपके पास भी दिमाग होगा, आप भी दिमाग वाले होंगे. So it's not that only the neurologists have brains, not at all. It just depends upon the aptitude. And I am glad and honored to be here, certainly. So I am Sushma Sharma, and I'm a neurologist. I did my neurology training from Jipmer, Pondicherry. I basically belong to Jammu and Kashmir. I've done my schooling in Jammu, and I did my undergraduation in Jammu, and I did my MD medicine in Kashmir, Jammu and Kashmir again. And then I did my DM in Pondicherry, Jipmer, Pondicherry. And I have chosen to settle in New Delhi, like Delhi NCR. I'm living in Delhi and practicing in Faridabad, Metro Hospital Faridabad, where I'm heading the Department of Neurology currently. And that is it. And I developed interest in vestibular neurology or neurotology, as our ENT colleague like to call it, in around 2018, when I went to a conference in Belarus, where I met some of the ENT colleagues. And after that, there was no looking back. Then I attended some of the Cyclops meetings. And last year I did I then did this Avista course. And then I did, last year I did the Cyclops certification course also. And I'm running a vestibular balance and vertigo lab, which is attached to neurology department in Metro Hospital Faridabad, apart from other neurology work.
Wonderful. So to complete the picture, Dr. Gyan from PGI, my alma mater, go ahead. Few words about yourself.
Thank you, sir. So, thank Inviting and giving me the opportunity, sir. Thank you. First of all, thank you. Myself, Dr. Gyan Singh. I belong to state of. I did my schooling from Rajasthan and did my graduation from Maulana Medical College, New Delhi. Then my post graduation did my post graduation from PGI Chandigarh, and same continued by senior residency from PGI Chandigarh. I had interest in otology. So after finishing my senior residency, I went to Seer Institute for 3 months for some to open up my it's a place what it was from where it was the various other knowledge.
Good. Your voice is cracking up. Is there a problem with your net? Okay, but
Am I audible?
okay, yeah. Is there a problem with your internet? You're fading in and out. Your video is not moving.
Assistant professor. I'm working as assistant after in 2019 assistant professor ENT, and I look after pediatric ENT and otology in.
Very good. So I think now we can start the meeting proper. So may I invite Dr. Sekdar to share his interesting case so that we can discuss and take this forward. Dr. Abi, please. Hello. Yeah.
Ravi, you need to unmute yourself.
Yeah, can you hear me?
Yes.
Yeah.
Am I audible?
Yes.
Yes, very much.
Oh,
Yes.
fine. So today we'll talk about migraine-associated vertigo. First, you have to understand the epidemiology. Around 10% of the population has migraine, of which 1/3 would be having vertigo. So that accounts for 3% of the population. This is a huge number. So possibly we are missing the cases. Most self-diagnosed sinus headaches are also having migraines. So again, maybe we are missing the migraines and we are missing the migraine-associated vertigo. Migraine is 3 times more common in females than in males. In 3/4 times, it stops during pregnancy. It is 10 times more common during the periods, and sometimes there is a postmenopausal flare. Manias and migraines have an overlap because mania causes vestibular activation that itself can trigger migraine. Sometimes even 50% population of manias can have a migraine. By the strict diagnostic criteria, migraine-associated vertigo happens in 10 of 1,000. On the other hand, manias is only 2 of 1,000. So again, while we are diagnosing manias many times, mostly we are missing the migraine-associated vertigo. Even when we are treating manias, there's some sort of avoidance therapy which also works in migraine. And many times in manias, we give intratympanic gentamicin as a chemical labyrinthectomy agent. But this kills off the labyrinth. So before giving an intratympanic gentamicin, we must be very sure that we are dealing with the manias and not with the migraine-associated vertigo. So now if we go for the actual diagnosis of vestibular migraine as per Baronese Society, it states that there must be 5 episodes of vestibular symptoms of moderate to severe intensity lasting for 5 minutes to at least 72 hours. Now we must understand that we are not talking of only vertigo, but vestibular symptoms. Vestibular symptoms can be divided into 4 parts. That is vertigo, dizziness, vestibulovisual symptoms, and postural symptoms. In the next slide, I will elucidate what I mean by these 4 terms. So other than the 5 episodes of vestibular symptoms, which has to be moderate to severe, lasting between 5 minutes to 72 hours, there should be a history of migraine, that's the second point, or a presence of migraine during at least half of these vestibular episodes. So now you can have a confirmed diagnosis of vestibular migraine when all the three components are present, the first, the second, and the third. And you have a probable diagnosis of vestibular migraine when along with the first, either the second, that is the history of migraine, or the presence of migraine during at least 50% of the episodes are present. This is a very crowded slide. I'll go through it slowly because this will give you an idea of what I'm talking about. So when I had talked about vestibular symptoms are divided into vertigo, dizziness, vestibular visual symptoms, and postural symptoms. What do I mean by vertigo? By vertigo, it means either there's a sensation of motion when there's actually no motion, like in Maldi debouchement syndrome, which is basically when you get up from a ship after traveling long, you come on solid ground and you still feel that you are having motion. Or it can also be a distorted sense of motion when the normal motion is there, like you're moving your head normally and you're feeling vertiginous, like as in BPV. Now we must understand what is the difference between a vertigo and a dizziness. In dizziness, there is a distorted sense of orientation when there is no motion. Both vertigo and dizziness can be either spontaneous or it can be triggered. If it is triggered, there are various causes of trigger. It can be positional, in which case the vertigo dizziness part will happen only after the head position has changed with relation to gravity. On the other hand, it may be head motion induced, in which it happens during the head movement with relation to gravity. It can also be triggered by sound or by Valsalva. There can be an orthostatic factor. By orthostatic, what I mean is that it will only happen when patient is standing up, not when rolling over or sitting down. Or there may be other causes of trigger also. Now, coming to the third point of the vestibular symptoms, there's something known as vestibular visual symptoms, which will happen only when the eyes are open. There can be something like an external vertigo in which the nystagmus will be unidirectional. In oscillopsia, you have a bidirectional nystagmus. Typically, in case of bilateral vestibulopathy, you have oscillopsia in which you have bidirectional nystagmus. There can be a motion blur. There can be a visual lag or a visual tilt. In a visual lag, the visual surroundings and head movement do not match. There's a lag between that. On the other hand, the visual tilt, the visual surround is oriented off the true vertical. This is usually more asymptomatic and of a longer duration. And last comes the postural symptoms. The balance symptoms to maintain the postural stability only in the upright position is taken as the postural symptoms. In this, there can be unsteadiness in which you tend to fall in any direction, and this reduces when you hold on to something, unless like it through vertigo. Or there can be a directional pulsion when you tend to fall in one side. Then there can be two things known as a balance-related near fall, when you nearly fall but you don't fall, and a balance-related fall. But in both these cases, the consciousness is preserved. This was the strict diagnosis, but for day-to-day, how do we go about it? You can have a nystagmus which is downbeating or upbeating, commonly present in the positional testing, but does not fulfill the typical criteria of BPV, like having a latency or a crescendo decrescendo or a reversal on sitting up. It can be bitorsional, looks like a bilateral BPV, and sometimes it may look like having a cerebral component. So, in a clinical judgment, when I'm looking at headache and dizziness, my red flag should be up. There should be a lack of alternative explanation by normal ear examination and CT and neurological examination. We should have a high degree of suspicion, especially of women of childbearing age. There's sometimes 50% history of migraine, and they respond to migraine medications like triptans.
Okay, so if I may interrupt you, Abhik, at this point,
Yeah.
let me just bring in an opinion of Dr. Sushma Sharma. Dr. Sharma, are you there? Hello? Dr. Sushma?
Yes, I'm very much here, sir. I just got a phone call
Just,
from
so
ICU, so I had to
let me
take
just,
it. Yeah, could you please
Dr.
rephrase? Yeah,
would apologize. I want to apologize to you for breaking your flow, but just to
no
bring
problem.
you in at this point, Dr. Sushma, you see a lot of patients of migraine.
Yeah,
How many of
yes.
them, referring to his first slide, how many of them do you actually feel have migraine vertigo, or how many of them you feel have vertigo alone as a symptom?
When I think 30%, if you ask me from my anecdotal experience, 30% I think is actually an underestimation. When we start seeking, usually patients come to us primarily with headache, and some patients come to us primarily with vertigo. But what I've seen is after I started having interest in vestibular neurotology, and I started seeking vertigo symptoms in patients of migraine, I realized that many of them, I think it is more than 30%, though I don't have a formal data, many of them agree to vertigo. So, non-troubling or non-disabling kind of vertigo, which is not the predominant symptom, with the predominant symptom being headache, photophobia, phonophobia. It is just like phonophobia, photophobia. Patients do not themselves tell about it. We ask about it. Likewise, ever since I started asking about vertigo, I think the incidence is just slightly less than photophobia, phonophobia, which is there in around 80 to 90% patients of migraine. So vertigo, I feel it's very rough, and I'm just saying it out of my memory kind of thing. But I think it's around 40 to 50% patients of migraine will agree to vertigo when we are or dizziness
When you
or
ask.
other vestibular symptom when we
I'll just
ask
pass
about
this
it.
question to Dr. Gyan. In your experience, patients who have who present to you with vertigo, how many of them would have headache as a symptom? I mean, you
Very
don't have to be
interesting
exact.
question, sir. Yes, sir. Actually, patients come to us with vertigo symptoms and headache on one or two patients 10 on ask question they will say about headache. Majority of patients they do not generally complain of headache because headache of the time generally doesn't have symptomatic episode. The episode the patient is having vertiginous
Gyan,
episode.
if
So
Ravina, if I may interrupt, we can request Dr. Gyan sir to switch off his video so that his voice quality is at least better, because there's definitely a bandwidth issue there.
okay, fine.
Yeah,
Now my
go ahead.
is
Yes, it's
my
better,
voice
sir.
better? Yeah. Yeah, thank you so much. So, majority of the patients do not generally complain of headache at the time of presentation. Maybe one or two out of 10 patients complaining of headache on asking the question. Otherwise, majority of the patients will have only vertiginous symptoms. Other some maybe with or without aura, but headache generally doesn't happen when they present to us.
Fair enough. So you have you have two contrasting opinions from the neurologist who says that
No,
most
sir.
patients with migraine will
No,
have vertigo, and
no, I'll just if I may just interrupt, I don't think there is any contrasting opinion here. I completely agree with Dr. Gyan when he says that patients who present
don't get me wrong. I'm
predominantly with
not.
vertigo
No,
will
please,
not
don't
complain
get
of
me wrong.
headache.
I'm
Okay,
not trying to be Arnav Goswami. I'm just saying there
of
are two
course.
contrasting viewpoints here. While Dr. Sushma talks about most patients of headache,
Headache.
migraine
Yes.
headaches, agreeing to vertigo, while if you ask the otoneurologist's opinion of patients who have vertigo, very few of them are actually concerned about the headache. They're more upset about the vertigo.
So I think
Please
it is
go on, Dr.
basically the
Siddharth.
same spectrum. It is basically the same spectrum of disease, And what happens is that more of the vertigo spectrum goes
we'll,
to our
we'll
ENT
analyze
colleagues and
this
more of
further.
headache spectrum
No,
comes to
let
us.
us get Dr. Sikdar back to continue with
Yeah.
his talk.
Yeah.
Thank you.
Okay.
Dr. Sikdar, please, please carry on.
I cannot shift my slide.
Oh.
Just a minute, sir.
Sir, you can
Yeah,
stop
fine.
sharing.
Fine. Yeah. It's fine. It's fine. Okay. So
Sir,
can you hear me? Yeah.
Yes, we are able to hear you, but we can't see your slides as of now, sir.
No,
I
can showing that you are sharing.
I can.
You are screen sharing.
I can.
You can see, sir? Okay,
Yeah,
okay.
Yes, I can.
Yeah, we
Okay.
can see.
Can everybody
Okay.
see? Can
Yeah,
everybody see?
we can see your
Okay,
slides.
fine. Okay,
Yes,
fine.
sir.
So again, to cut it short, during vertigo, there may be presence of migrainous symptoms like headache, phonophobia, photophobia, osmophobia, and one more thing also you should ask, that is about cutaneous hypersensitivity or kinesthesia. Sometimes patient will say, I feel this area feels a little different, I feel a little heaviness, nothing painful, but regarding the cutaneous hypersensitivity, and this migraine-associated vertigo can be precipitated by the migraine triggers and similarly are relieved by anti-migraine drugs. There's some problem regarding shifting of the slide. Okay, fine. Okay, so now, what other things are there? There can be a transient bilateral low-tone sensorineural hearing loss, which is of transient nature. There is a positional but a persistent nystagmus in the offending position in the dark. This is unlike pure BPPV because this is persistent. And the typical triggers for this is of the vertigo is flashing of light, sleep deprivation, periods, exhaustion, sometimes season change. The food things are chocolate, cheese, ajinomoto, processed food, and coffee. But if you are regularly having coffee, then even withdrawal of coffee may cause a rebound of vertigo. If you do a VNG during the vestibular migraine,
can I just come back to a small discussion? You mentioned osmophobia. What was the term you used? Photophobia and osmophobia.
That's right, sir.
Right. Could you clarify what is meant by osmophobia?
By that, what I mean is that fear of strong smells. Any strong smell sometimes precipitates the attack. Like when they're cooking and there's a very strong smell, or they go to a very public toilet or something, they also sometimes have this problem.
So this is classical. You're talking about classical triggers for migraine.
Yeah, that's right, sir.
Right. So, I mean, I don't know about your literature review of how many of these symptoms are classical about vestibular migraine, but you're saying in classical migraine you would get all
that's
these
right,
triggers.
in classical migraine. These are the triggers of migraine.
So,
and any migraine trigger, even the vestibular migraine, will also have that vestibular feature.
Now, do you see a difference in vestibular migraine triggers versus general migraine triggers?
I think the triggers are the same. Photophobia and phonophobia are well recognized and they are included. Only difference is that they are included in the criteria. Osmophobia certainly is well described, though not included in the criteria, but it is a well described trigger of migraine. And many migraine patients will agree to getting their migraine triggered by perfumes, so they do not use. It's not just the bad smells; even perfumes they cannot, take. And cooking smells, as rightly said, and the toilet smells, and any strong smell can trigger migraine in such. And I think the triggers are the same when we ask. They turn out to be the same.
Please continue, Dr. Sikdar.
Okay. So if you do a video nystagmography during the vestibular migraine, there's something which can happen. Like medicine is not exactly what it is, not a pure science. You can have some classical features, you can have sometimes present something, sometimes not. But classically, what you see, you have a smooth pursuit which is impaired. This is more in the vertical than in the horizontal part. You may have spontaneous nystagmus in the dark. You can have a positional nystagmus, but this will not follow the crescendo, decrescendo, and the reversal pattern of BPPV. And one more thing, if it is there, it's really pathognomic, but it's not always present. That is, if you're doing a dynamic visual vertical. The normal value of a dynamic visual vertical is less than 3 degrees. it can have a little deviation on the right in the clockwise background and to the left in the anti-clockwise background. But if the deviation is more than 3 degrees, then it is very much pathognomic of vestibular migraine. This was one of the patients I did, which I'll be presenting now. This was a 40-year-old lady who had presented complaints of lightheadedness since 7 to 8 months. This is associated with headache and neck pain. There was no obvious trigger initially, but later she said that she had some abnormal feeling of sensation when she was having this vertigo abnormal feeling of sensation on the ears. It was non-positional in nature. There was no history of any decreased hearing or tinnitus, and patient was vegetarian having irregular milk intake. Physical examination showed there was no postural hypotension. Rhombus test was normal, but in Gutenberger test, patient deviated around 15 to 20 degrees to the right. Now, when I went in for the smooth pursuit, as you can see, the horizontal smooth pursuit is more or less okay, but the vertical pursuit has a lots of breaks. And if I'm checking the nystagmus, in light, there's hardly any nystagmus. This is the upper panel, is the tracing in light. The red is for the right horizontal, the blue is for the left horizontal, as you all know. The black is for the right vertical and the violet is for the left vertical. Here you don't see any nystagmus as such. But on the other hand, in dark, patient had an upbeating nystagmus, as you can see here, as well as a right beat, as you can see here. The upbeats are very well seen here. Upbeat, upbeat, right beat, right beat. This is the video recording. Initially, you can see some amount of right beat here. The recording always does not pick it up. Many times it is the graph which gives you a better idea. Like in this case, the recording is not picking up too much, but the graph was classical. So after the spontaneous nystagmus, I went for the gaze cyst without fixation. Here, I was having a left beat. Initially here left beat, then again right beat, and upbeats. When patient was looking to the left, please ignore the right eye. There was some problem with the camera. In the left eye, as you can see, there is left beat on gaze test to left. This is very well seen in the video. That's a left beat. Again left, left, left again, left, 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 left again, left. So we have a left beating nystagmus on looking to left in dark. Now, when I'm looking to the right, you can make out some right beating nystagmus at the start of the graph. I'll run this. This is to the right. Yeah. 1, 2, 3, 4, 5, 6, 7. I'll run this part again once more. 3, 4, 5, 6, 7, 8, 9. Now, I went for the gaze test up without fixation, that is in the dark. Now, when patient is looking up, you can see the upbeats here, the vertical, upbeats here, the vertical, and there was some left beat. Running the video, there's some amount of left beat and upbeat. That's an upbeat. Left beat again. I'll run this start part once more. left beat, left beat, left beat, left beat. And after this comes the gaze test down without fixation. Here, if you can see at between 28 to 34 seconds, you can see very nice up right beats here, right beats, right beats, right beats, and also upbeat. It is usually difficult to the gaze test down. We have to ask the patient repeatedly to keep the eyes wide open. Otherwise, it is difficult to record in the video. Let us see here. Patient is looking down. I have to ask him to keep his eyes wide open. Many times better than the video, it is a graph which you see. So again, ask him to keep his eyes wider. I have not given the pictures of the positional test because there was no specific finding in that. And then I went for the subjective visual vertical. The subjective visual vertical dynamically, when I did in the clockwise direction, the value was 4 degrees, which is more than 3. Similarly, in the anti-clockwise direction, dynamic visual vertical, I had a deviation of 6 degrees to the left, which is again more than 3. So this was very classical. So what was the impression from our VNG? There was no spontaneous nystagmus in dark. There was spontaneous nystagmus in light. Sorry, there was no spontaneous nystagmus. In dark, there was spontaneous nystagmus, which is upbeating nystagmus. The red flag here, or the important part, was that there was a gaze-induced direction-changing nystagmus, which shows that it is likely to be a central cause. Post head shake, there was normal finding. Positional test was non-specific. The subjective visual vertical was significant, more than 3 degrees. Pupil audiometry was normal. So I made a diagnosis of vestibular migraine.
So, no, so I think I could just hold back here a little. And let's get in opinions of Dr. Gyan first. Dr. Gyan, if you were to have come across a similar case, would you have thought of vestibular migraine at the first pass?
The kind of nystagmus that has generated uh, in the VNG, we can see that. In general, the central nystagmus have very small slow phase velocity as compared to the peripheral nystagmus, which has a very high. The slow velocities are much more robust. Central pathologies they create a very mild slow phase velocity,
Could you
like we
speak
can
up
see
a
as
little?
Dr. Abhik
Could you
has
come closer
shown.
to the mic?
Yes, sir. Generally, the peripheral central vertigo have a very slow phase velocity are milder as compared to the peripheral ones that we can see. Any upbeating nystagmus, it is also a red flag sign, and gaze evoked bilateral direction changing nystagmus is also another red flag. I would definitely, before making a diagnosis, I would like to have an opinion of a radiologist and get on some scan done to check for any other causes before making a diagnosis of vestibular migraine. Won't we have as a first diagnosis, but definitely as a second close to another etiology I'm not missing. So making a diagnosis, I would like to order a scan.
Dr. Sushma, what do you feel?
I think from the clinical presentation, vestibular migraine certainly is there in the differential diagnosis. But I would also want to rule out, because vertigo is the predominant symptom and in a female. And I would also like to rule out multiple sclerosis, demyelination of the brainstem, which can sometimes present only with vertigo. So and there are some other differentials of the brainstem like vascular or other pathology. Vascular is unlikely in this case because it's not a sudden onset thing. So as I would agree with Dr. Gyan that I would like to order a MRI in this case. CT will not do because CT will not pick up the demyelination. I would have done MRI, and only after the MRI is normal, then of course vestibular migraine becomes my topmost differential, and VNG certainly is supporting vestibular migraine, and especially the findings of spontaneous nystagmus in dark, which is upbeating nystagmus, and subjective visual vertical, which is significant more than 3 degrees. I have a bit of concern about the gaze-induced direction changing nystagmus, though obviously it points to a central pathology. But I think the patient was looking too much to the right and left, and at this, usually when we check nystagmus, we ask the patient to move the eye only up to 45 degree and not to the end, because at the end it is normal to find this much degree of nystagmus. So this much degree of nystagmus, even if we check in ourselves to the extremes of gaze, we will find. So probably that part can be ignored, but still there is spontaneous nystagmus, upbeat nystagmus in dark, and there is subjective visual vertical, which is more than 3 degrees. Certainly it is consistent with vestibular migraine. If the MRI is normal, then we give, it will be certainly diagnosed as vestibular migraine only. I would diagnose the same. I agree with the diagnosis.
So to
Provided the
summarize,
MRI is okay.
To summarize, I think the viewers who have clocked into this should take home at least these messages that number one, between vertigo and migraine, there's a strong relationship. Though more in one direction, where you have a lot of patients who have migraine confess to vertigo and not vice versa. And also that the findings of vertigo are some ways mimicking central pathology findings, and therefore before you jump to vestibular migraine, it might be wiser to rule it out in terms of radiology, as was pointed out, and an MRI, because even within the neurological symptoms, there could be a host of causes which could cause this.
Yes.
Please carry on, Dr. Sikdar.
Yeah. So now I'll be going to the therapy. So my therapy is basically divided into 3 parts: avoidance, preventive, and abortive. So in avoidance, I have to avoid the things which are causing migraine, which is the same cause as the vestibular migraine. So avoid artificial sweeteners, chocolate, high salt, coffee, alcohol, and smoking. I like the patient to avoid stress, loud noise, bright light, and strong smell. In the preventive part, many of my patients I treat with beta blockers like propranolol. This is started around 40 mg per day, but can go up to 120 mg. While it is safe in pregnancy, it has known side effects of hypotension and erectile dysfunction. Calcium channel blockers like flunitrazine and cinnarizine can also be given. These are also having side effects of hypotension and constipation. Amitriptyline and nortriptyline are used very commonly. They can start at a 10 mg dose and can rise up to 50 mg at night. It is safe in pregnancy, but causes sedation in higher doses and also causes weight gain. One good drug to be used is topiramate, which is basically an anti-epileptic. It can be started at 25 milligram twice a day, can raise up to 100 milligram. One of the good side effects this drug has in this patient population is weight loss. Many ladies like to lose weight, and this can help in that. However, one must be very careful. Topiramate is a teratogen, so you must ask the patient that they should not conceive when the drug is being given, and it may also worsen narrow angle glaucoma. Magnesium is also used 1 milligram twice a day. This, in a way, sort of stabilizes the membrane and has other mechanism of action also. However, even after a patient is avoiding the stresses and having preventive medication, if they have a breakthrough problem, then actually I treat with sumatriptan or abatriptan. This is the post-op. 1 week later, I had asked the lady to come and meet, and she's giving feedback of how she's feeling.
Able to hear the sound.
Are you able to hear the sound?
No.
Very soft. But you could tell us what she's saying.
She says that she's better. The vertigo is better than the headache. The headache has regressed, but vertigo has regressed more than the headache. This is around 7 to 10 days after I have started therapy.
What was started in her?
Madam, I started other than the I started Betalog TR 40 mg at night and Topirol 25 mg twice a day and magnesium 200 mg twice a day. Magnesium 200 mg twice a day.
Well, let us.
Yeah.
Do you want to say anything more, or can we just open up for discussion?
Sir, this is the last slide. So, if there's a high suspicion of headache and vertigo, you should do proactive history taking regarding the triggers of migraine. And if there's an intermittent vertigo with neurologically stable patient who has no focal signs like ataxia, dysarthria, or diplopia, dysphagia, etc., and having diastasia and nystagmus, think of migraine-associated vertigo again. Actually, just like Madam had said, basically there's a vast population having migraine-associated vertigo, which we are missing. So we should be able to diagnose cases and then there will be benefit. That is my take-home message.
Good. So now let us dissect this a little further. So the question to you, Gyan, is would
Yes,
you
sir.
feel confident in treating a patient of vestibular migraine on your own, or would you like to involve a neurologist?
We have a neurologist who looks after migraine, who looks a lot of migraine patients. We generally involve them in our decision making as well. Although I make a diagnosis of vestibular migraine, I give acute when that is when it is necessary, like in the form of if the vertigo is acute, the patient is having a lot of stressful situation. In a majority of patients, they have some antecedent history of stress in the past week or some familial issue, or many patients do not give a characteristic of food or any kind of, because in India tea, wine are majorly consumed over here. The very common history is a history of stressful insomnia, sleep, which was common. And after making a diagnosis, we start with we tried the acute condition with mechanism treatment. Then I generally refer our neurologist to start any kind of
You're not
prophylactics.
very clear. Could you just come
But
closer to the
many-
mic and speak up? Maybe speak a little slowly.
Yes, sir.
Sir, in the meanwhile, can I pose a question to Dr. Abhik Sikdar? Is it possible?
Please go ahead.
Yes, Dr. Abhik, sir, first of all, good presentation, sir.
Is it Krupa speaking?
Hi, sir. Yes, that's very much me, sir.
Yeah, tell me.
Yes, sir. Sir, was there, as far as I saw, I didn't recognize, but was there any rebound nystagmus in this patient in the VNG findings that you mentioned?
No, there was no rebound as such.
Okay, so because nowadays we are seeing a lot of patients and there has been a pattern of a rebound nystagmus. And of course, although it is a more, it is a more specific, this one, rather than a sensitive finding. But that is one thing I would like to add to your VNG findings since you're presenting a migraine test. Yes.
Sure. Thank you.
Although I of course, sir, I just missed that. So I was just confirming with you whether there was a
there was
rebound.
no rebound. There was no rebound.
Okay, sir. So, sir, next question. Yes.
Am I audible?
Yeah, go ahead, Gyan.
Hello.
Yeah, go ahead.
Go ahead,
Yes, sir.
please.
Somehow yes, some issue was there with my earphones. So that's what actually, sir. Come back to your question, sir. We treat with the acute symptoms that the patient has presented, but if the patient requires on treatment, I generally prefer it to the neurologist who looks after the migraine department in the neurology departments.
Okay,
I
Dr.
hope it answers
Sushma,
your question, sir.
let me bring the question to you. Do you all have any step ladder approach to treating migraine?
Yes, certainly, yes. We do have a step-ladder approach to treating migraine. In category one, like as a first drug of choice, you usually use either amitriptyline or beta blocker or flunarizine. These three are the first tier drugs in migraine, and we use one of these, not all the three, or not two of them together. One of these is usually started in the
So
first
you
year,
use
depending upon the
beta
patient profile,
blockers, amitriptyline,
and flunarizine, calcium
and
channel blocker.
phenarizine. These
Yes.
would be your
No,
first
not
steps.
phenarizine, flunarizine.
Flunarizine. These are your
And
first
flunarizine.
steps.
Yes.
These are
Okay.
our first step. And after that, if the patient still doesn't respond to the first line drugs, then we go to the second line, in which we use topiramate or divalproex, depending upon the patient profile we choose. And or there can be a intermediate tier also, where we may combine two of the first line drugs. Like I may use a beta blocker with flunarizine, or I may use amitriptyline with beta blocker. Uh, before going on to the second line drugs need more monitoring and have more adverse effect profile, so we do not use them as a first go. And only in patients who are refractory to the first line, then or to the combined first line, then we go to the second line therapy, in which we use topiramate or divalproex. If the patient would still not respond to it,
just to repeat, you use valproate and
topiramate, either of
okay.
these, not both
Either of
together.
them.
Yeah, and if the patient would still not respond to the second line therapy, then we go to the next line, in which we use Adenoma, which is a monoclonal antibody, once a month subcutaneous injection, or in chronic refractory migraine headache predominant, not vestibular predominant. There we may use therapeutic Botox injections also. And nowadays, so this is the tier basically. Nowadays, there is
So,
one more device in
in
migraine,
your
which we call,
experience, patients with vertigo, have you
yeah.
usually got away with the first line treatment? And how many cases would you have used second line?
In patients with vestibular migraine or vertigo predominant migraine, uh, I usually start with amitriptyline, and rarely I have to change to flunarizine. Um, Very few patients, I would say, I had to go to divalproex. Topiramate I have not used in any migrainous vertigo patient. And then, of course, the other trigger avoidance and lifestyle modifications, they have to be done, no doubt. But yes, it's very interesting. Now that you're saying it, I realize it that I have very few of my vertigo predominant patients I had to use divalproex. In most of them, I have used either amitriptyline or flunarizine. I haven't used beta blocker also much in these patients. Either flunarizine or amitriptyline would work.
So
Nothing more,
I,
only
I
this.
have one more question. How have you ever tried non-allopathic treatments of any sort?
Of course, we ask for all lifestyle modifications, which is a non-pharmacological approach, which we will not call it non-allopathic, but it is non-pharmacological. And I haven't used any unapproved therapy for migraine. I have stuck to modern science only. But just there is one new device in migraine, which has been recently approved in India also. It is called Nerivio, and it works by remote electrical neuromodulation. It is basically the concept is very similar to acupuncture or acupressure concept. So as you said, some other unapproved, we do not use anything unless it is integrated into modern science, modern medicine, and allopathy is not averse to using anything which works and which is proven to work. So I mean, it's not that that it belongs to. So Nerivio is a new device which is very much inspired from acupressure or acupuncture. It works by remote electric neuromodulation. In fact, I have one device with me here. It's in package. I'll have to open it. Can I show it, sir?
Sure, sure.
Okay. Just give me a second. Recently only we had a ad board meeting, and this device has been now launched in India. It is already approved in US and Israel, and also in Europe, not in China. It is this kind of a device, if this is visible, this kind of an armband is there. It is still packed, so I am not opening it. This kind of an armband is there, and it has basically the armband is tied to the upper arm at around the triceps, and it keeps on giving pulsed electrical stimulations, which basically give a sub threshold. Like, it is not painful, but it's still noxious. It keeps on giving that stimulus, which is carried by the peripheral nerve, A delta and C fibers, to the the pain sensitive pain sensing centers in the brain, including nucleus raphe and all. And from there, the conditioned pain response starts, and endogenous opioids are released, which would then take care of any other pain in the body. So it's
I
just
think there
same
are
principle as that of
variants of this.
acupuncture. It is approved.
There are
Sir?
variants of this device.
Yeah, there are variants. This one is the only one which works by remote electrical neuromodulation. Then there is another device in migraine nowadays, which we call as Kifali. Kifali, the device is applied over here, and that also gives pulse stimulation. It is just like, applying pressure. So that again is what we have been using in India. People have been using Navratan oil, pressing the head, tying a band over the head. See, all these have a thorough scientific
And
basis.
I
This
think
is not just
there's a transnasal balloon which has also started coming
I
into
am not
this.
aware of that, sir. If I don't
Yeah.
think it is approved, if it is, I don't know if it is approved. But whatever I told you, Kifali, Nerivio, these are approved. There is another one, I forgot the name, where the vagus nerve is stimulated over here. Just handheld device just has to be kept over vagus nerve. So now the research in migraine is also now advancing in neuromodulation segment, which is what our traditional therapies have been based on all through the years.
No,
But of course it is a scalable, because it is a device, so it is scalable. It can be given to anyone. It is it makes it scalable to a large population, having a approved device.
So I think now it might be a good time to throw open the discussion to the other attendees on this grand round. So if there's
Sir,
anybody who would like to intercede,
yes,
give their personal experience, we'd be more than happy to hear.
sir, may I ask my question? I would like to pose to Dr. Sushma ma'am and probably Dr. Gyan sir. Is it possible, sir?
Yeah,
Shall I
go
go
ahead.
ahead? Sushma ma'am, so earlier in this discussion you mentioned regarding you would definitely order an MRI in this case. So
Yes.
I want to learn from you, ma'am, what are the findings you're looking for in the MRI of this patient, or rather to rule out migraine? Yeah.
No, see, for migraine, I am not looking for anything. In migraine, I expect either a normal MRI, or at the most some non-specific hyperintensities can be, flare hyperintensities can be found in migraine patients. So, but
Okay.
what I want to rule out by MRI is basically either a brainstem, uh, most importantly, multiple sclerosis, which is common in this age group, can present only with migraine and is common in females. And multiple sclerosis with a brainstem plaque, which is basically brainstem demyelination, can give
Okay.
rise to similar kind of thing. And that
Multiple
will
sclerosis
not
is
be
known as
seen on CT also.
Okay, ma'am.
multiple sclerosis is
Anything else?
Yes, Dr. Abhi.
Anything else, ma'am?
multiple
Like
Yeah, otherwise, another thing is any brainstem structural, mass occupying lesion, or any, brainstem structural mass occupying lesion like a glioma, etc. I would not think
and
of vascular in this. My main thing is to exclude a multiple sclerosis, because we have
as I was
seen
saying,
patients coming like this.
multiple
Yes,
sclerosis
please,
is a
Dr.
great
Abhi.
it's a great mimicker. It can mimic
Great
anything.
mimicker,
okay.
yes,
It's
it
a
can
great
mimic
mimicker.
anything. We need to rule
Okay,
it
ma'am.
out in this age group. We cannot afford to miss an attack of multiple.
It's a great
Oh,
mimicker.
The earlier it is diagnosed, the better we can treat it. So we need to rule that out.
okay. Thank you, ma'am.
Good evening, Sushma madam.
Yes.
Hello,
Good evening.
I'm
Good
Dr.
evening.
Danya from Cochin. Yeah,
Yes, Dr. Danya.
I've heard you talking before also. So my doubt is, madam, what about the late onset migraines? Like many of the
Yes.
patients now, they don't have an early history of migraine, and when they present with vertigo and I evaluate them, I usually get the findings in VNG suggestive of migraine, and like they don't have the previous episodes also. So how often you come across late onset migraines, like
Like
after
what do you
50 and all?
define as late onset? How many, like what age?
Like after 40s, I come across commonly. And today I had a case today.
Can happen,
One
yes, can
82-year-old,
happen yeah, 82 years.
82-year-old lady. Yeah. Press. Am I audible, madam?
Yes, you
Yes,
are
ma'am.
very much audible.
Yeah. 82-year-old lady, previously evaluated by neurologist in 2022, like December, with an MRI. And perfectly it was normal, and now her presentation is for the last 2 months she has got a symptom of vertigo suggesting positional vertigo. So I did a routine VNG today, and during the positional test she was having typical, continuous downbeats and upbeats, and SVV affected by SVV influenced by the background, and she has no previous history of migraine, and now she has got headaches for the last 2 years, occasional unilateral headache. So like she was evaluated by the neurologist before, and now she has come to me, and I cannot get a diagnosis. So I was thinking whether it's a late onset migraine, but later too is too late, right?
Yeah. So 40 years is not late at all. In fact, around 40 years, usually we say that migraine is a disease between the most prominent between 20 to 40 years. But then around menopause, or the with hormonal fluctuations, and many females even without menopause, um, when they are even not yet approaching menopause, many females are on hormonal pills for menstrual irregularities and other things, and that can also trigger migraine. Then there is work life strain. 40 years, your children, the children will be, one child would be mainly maybe 12, 13 years old, the other child might be just 5, 6 years old, and then there is work and there is home, and there are a lot of stressors, and the migraine may become manifest. Otherwise they might be having a latent migraine which they never bothered about, and then it might have become manifest. So 40 years,
May,
certainly, without much thinking, you
if I
can
may
make a
interrupt here,
diagnosis of
ma'am,
migraine. It is
we have
not
questions
uncommon.
on the chat.
82 years, yes.
There's some questions on the chat, and we are running out of time. So
I'll
maybe,
just complete
Danya,
the
you
answer
can
to this.
connect offline with Sushma to get more details. Is that okay?
Yes, sir, it's
We'll
okay,
help
very
you
much
connect.
okay. Yeah.
Sorry? Yeah, because I know for a fact that this is a vast topic. So we can actually go on discussing, but we have some constraints of time. So I just want to get some questions from the chat which ask basically, and Dr. Sikdar, you could try taking this. How do you connect migraine and vertigo? What is there a common cause in both?
So migraine and vertigo, migraine and menias.
Yeah. No. See, migraine is a
Migraine
headache
and
symptom.
vertigo, sir.
And you get
Migraine and vertigo is
vertigo.
the question.
What is the pathophysiology of them?
The pathophysiology of the vertigo from migraine.
Yep.
So I have to read through it. I think madam would be a better person to answer that. Sushma, madam.
Go ahead. Sushma,
Okay. So basically,
is there a
migraines,
common pathophysiology?
yes, certainly it is central, hypersensitization, afferent hypersensitization. So basically, there is your nervous system, the central nervous system. It gives a exaggerated response to the afferent sensations. When this exaggerated response is in the realm of pain, which is in the realm of the trigeminal system, trigeminal-vascular system, then we call it as headache predominant migraine, and it will present as present like headaches, more like headaches. And when it is more in the when this realm is more in the vestibular system, so it is basically fifth nerve and eighth nerve. So when it is more in the vestibular system, then this is the same disease. Just like, stroke is one disease, but if stroke is affecting the parietal lobe, then the patient will have upper limb dysfunction. And if the stroke is also involving the frontal, then the patient will have a lower limb dysfunction also. And if it is also involving the Wernicke's area, then the patient will have aphasia also. If the stroke is in occipital lobe, then the patient will have visual symptoms, but the disease is the same. It is only which part of the brain, because brain is highly specialized in different parts of the brain, subserve different functions. So which part of the brain is affected at that particular time by the same disease will lead to different presentation. Just like that, in migraine and vertigo also, the underlying pathophysiology is the same, which is central hypersensitivity to the afferent stimulus and a little bit of phonophobia. All of us, if we are exposed to bright light for a long time, if I am confined in a room with very bright headlight for a long time, I'll start getting headache. Anyone will start getting headache if the stimulus is very strong. That is not migraine. But if with a little light also you are getting headache, that is migraine, because your system is over responding. It is responding to the subnoxious stimulus also, which it should not have. Likewise for vertigo, if your vestibular system is oversensitive and responding with vertigo, that is how the pathophysiology is connected for the
So here is
vestibular
a
migraine and
follow-up
vertigo.
question to that, ma'am.
Yeah.
Is so if you have vertiginous migraine versus Meniere's disease, how would you differentiate that clinically?
That answer will be better given by Dr. Ravi.
Yeah. Basically, Meniere's should have the typical feature of Meniere's is a fluctuating hearing loss, tinnitus, and vertigo, and which will usually increase as the time goes on. It will increase in intensity. So the tinnitus and the hearing loss part of 1 year is more in feature of Meniere's disease. On the other hand, Meniere's disease itself has some vestibulotoxicity that can trigger migraine, which I had talked initially. So basically, though there are two different diseases, there will be some overlap between these two diseases. I mean, migraine will not trigger Meniere's, but Meniere may trigger migraine.
Yeah.
Sorry, go ahead.
Yeah, first
Dr.
of all,
Gyan?
yes, sir.
Yeah, go ahead.
Yes, sir. In the migraine, the pathophysiology, currently accepted pathophysiology is spreading depression, where there is a wave of excitation happens over a particular part of the cortex, followed by inhibition. So this is what happens if any particular area it is no more considered as a vascular phenomenon. It is more of a cortical spreading depression over a neuronal activity. Yeah, certainly it's more of a neuronal activity. So any part of the brain or cortex then it creates the symptoms will be according to part of the cortex. That is in Meniere's disease.
True. It is no more the trigeminal was earlier given explanation. Nowadays, the vascular has been very rightly said by Dr. Gyan. The vascular theory is in the backlog now, and the current more accepted theory is the cortical spreading depression. Underlying principle remains the same. It is a central hypersensitivity syndrome. The underlying connecting thing remains the same. It is caused by, now it is understood that it is caused by cortical spreading depression, which usually starts from the occipital part, and that is why visual aura is seen in classic migraine, but then it can start from anywhere. When it is more in the trigeminal distribution, then it is pain predominant. When it is more involves the vestibular part of the cortex, then it is vestibular predominant. Yes.
And to add on to the next, second question, in the Meniere's disease, sometimes they are like the two sides of the same coin. They are like, the similar presentation can have hearing loss in vestibular migraine with kind of tinnitus and oral fullness. Many symptoms might overlap. The key feature that differentiates, or we can have a little bit of difference, is then in migrainous patients, the hearing loss that has been observed in various cases are mostly on the high frequency. In is mostly on low frequency side. It's low frequency.
Migraine, you said high frequency, and Meniere is low frequency.
It's low frequency. And second,
Meniere is low frequency.
Definitely once. Then it happens when we evoke imaginary potential. Various studies have come up, and we have done our own in WEMP analysis and Meniere's disease, vestibular migraine, where we have seen the cervical WEMP is more affected in the vestibular migraine patients, whereas both cervical and ocular WEMP are affected in these patients. our outcome from the study that we have done, but in literature, majority the
We lost you. Hello? And must thank you, Dr. Sikdar, for opening our eyes and refreshing our knowledge about vertigo and migraine. Thank you, Dr. Sushma, for enlightening us on new pathophysiological concepts. Thank you for highlighting classical VNG findings in migraine-associated vertigo. And I think it'd be very interesting to try to pool everybody's experiences in this regard. And I would try from my side to reach out to all of you all to see if you can get a kind of a prevalence data, because all too often we quote Western data while we should be talking about our own data. Last question on a follow-up is, how effective is treatment? Is there a tendency to relapse as you often see in migraine in the long term? Anybody could take it.
No, ma'am.
Usually patient has to, in vestibular migraine, I think patient has to continue treatment. What I feel, I don't have many vestibular migraine patients. I have many more headache predominant migraine patients. But what I have seen is that in headache predominant migraine patients, usually after 8-10 months, slowly, within a year, I take the patient off the medication, and then they remain good for good 2-3 years. When I have to restart it again for, it's like a pulse. I have to give it 1 year, then 2-3 years off, then again 1 year, then 2-3 years off. But in vestibular migraine, I have to continue. If I stop, they again start getting vertigo. So there is no period of, drug-free period. I keep on giving the drug to them.
In the audience, is there any opinions? I'd be glad to hear that. Otherwise, I think we would come to the end of this presentation. Anybody in the opinion in the audience? I see Dr. Garg is with us. Dr. Zubair, would you like to comment? Feel free.
So just one small comment before we close. I agree with Sushma ma'am. Vestibular migraine, the moment you stop that therapy, they will recur. They usually relapse and they come back. So this is one thing where I completely agree with ma'am.
Dr. Vinod, you're muted. Could you unmute? Your mic is muted. Yeah, go ahead.
Yeah. Hello, Ravi. I had few cases, so I don't have VNG and all that. But from history, I could make out that they are migraines associated with vertigo. I have treated them with Ciplar and flunarizine and had good results. I think about 6 or 7 patients for last more than 1 year. They are showing good results.
But do you have to discontinue the treatment or continue it?
So I am
without
reducing
stopping?
it. I've reduced it. One patient is only on Ciplar. Others, I started 10 milligram flunarizine. Now it's on 5 milligrams. Slowly, I taper it off. They are doing fine.
Thank you very much, sir. Thank you.
Previously, they were all on so-called this button and all. All that have been stopped. They are doing fine. I am happy.
Thank you very much. So I would like to end on this note of being extremely thankful for our resource persons, our presenters, and all those who have cared to share their opinions and tune into this broadcast. We will keep this program running on the same manner, and we will try to distribute some take-home messages to everybody who is interested in the topic of vertigo. And as I said, we should start gradually building a uniquely Indian database. Thank you very much.
Thank you.
Thank you, sir. Thank you,
Thank you.
Sushma ma'am,
Thank you so
Abhik
much.
sir, and Gyan sir.
Thank
Thank you.
Thank you.
Wonderful presentation, sir. Thank you.
Thank you so much. Thank you so much for patient listening. Yeah. Thank you, Dr. Abhik and Dr. Sushma. It was wonderful listening to you.
Thank you very much.
Thank you, everyone.
Great discussion. Thank you, ma'am.